Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. I felt like I was in an SNL skit.
Good point.
Oh, you're not going to sing?
Fresh, she's so fresh. She's so fresh.
Progress.
What's all that clicking? Quit all that clicking. She's fresh. I missed you.
Roll that beetle foot. Welcome to the podcast. I am Katie Kleber.
And I'm Elizabeth Mills. Thanks a lot, guys, for listening to us today and joining us.
We're going to be talking about documentation, and if it wasn't documented, it wasn't done. So in nursing school, you learn about documentation, but really they can only kind of broach like the subject because your documentation is very specific, depending upon the unit and the hospital and the system you're using. So we just want to talk about a couple kind of things to keep in mind when you're documenting. So documentation kind of sucks. Like, let's be real. I don't like documenting. It's tedious.
It's a legal document, though.
I know. I hate it. Anyways, you want to document things as a nurse, thinking that someone's going to read this in a deposition in 5 years.
And yeah.
And I say that like so seriously. Like, you want to think, okay, maybe everything went normally on your shift, but what if in 2 shifts or maybe the next shift your patient codes and dies and they're looking back at your documentation to see what went on with that patient earlier that day.
And in 5 years, are you going to remember that day?
You are not. Absolutely not. So it's important when you are getting your, I remember at any hospital you go to, whether or not you're a new grad, you're going to get some education on how to document and what the their documentation requirements are and how to document things. And I want to encourage you to pay close attention. Those are classes you can easily like zone out of, but I really think it's important for you to pay close attention to those classes, pay attention to the shortcuts. There is a lot to document, but just because there's a lot to document doesn't mean that you have to be inefficient with it. You can, the more efficient you are with documenting, the less time you're actually going to spend doing it. Mm-hmm. Doesn't mean you're going to do less documentation. You're just going to be able to get it in the computer faster. Mm-hmm. So we're going to talk about some practical tips to kind of keep in mind when you're documenting. And the first one really is to pay attention to those classes.
Yeah.
And making sure that have a focus on doing something quicker. So if you see someone knows a shortcut to something, like one of mine is, yes. I always use the keyboard as much as possible because using the mouse slows you down.
Yes.
So use the keyboard to scroll and click and select because that is much faster than the mouse. And I know people think it's like a minute amount of time, but it totally adds up. Totally adds up.
Another thing is I kind of have a system down. I've kind of
like a routine.
I chart my, verify my vitals first. Do that little section. I've used the only EHR I've used is Epic.
Yeah, that's one of the massive big ones that a lot of you listening probably have or will use.
Yeah. So I don't, there's different parts of the chart to go in to document. So I have a system, and that system kind of helps me make sure I complete all of my documentation.
Yeah, because you're doing it systematically. Right. So if you miss something, you kind of know it.
And going through and it's important to chart in real time, however possible that is.
And a way to kind of help you guys with charting in real time, because it's helpful, because rarely are you going to get 20, 30 minutes to sit back and catch up on all your charting. Mm-hmm. And if you think you're going to go to the nurse's station and chart for 30 minutes, like, that doesn't happen. Sorry, guys. Like, no, there's no
really
uninterrupted.
Want you to chart in the patient's room if you can.
Yeah, a lot of places really are encouraging you to chart in the patient's room. So,
although my patient the other night said, "What's all that clicking? Quit all that clicking." That clicking. So I was like,
sorry,
I was like,
I'm so loud.
Do you want me to leave the room and leave you alone?
Oh, you do? I guess I'll go chart at the nurse's station.
And 2 minutes later, he's on the call back.
The nurse life. So my
Stop all that clicking.
Yeah, stop all that clicking. Where'd you go?
I missed you.
Will you sit here next to me?
Hey.
That is exactly what it is to be a nurse.
What are you doing?
What you doing out there? What's going on with your other patient? What's the guy next door have? Tell me about him.
That person who just walked by, what's their name?
Oh,
It's so funny what people pay attention to.
Yes. And how many patients ask you about the other patients and what's going on
all
with
the
them?
time. Families, what's going on with that person next door?
I've had patients leaning into rooms to look, or I'm sorry, family members leaning into rooms.
Hey, do it.
Well,
You guys, family members, you cannot do that. That is patient privacy.
Public service announcement. Don't lean into somebody else's room.
It's just classic neighborhood gossip, and it beats.
It does.
It
No,
really beats
I am
counting the
not
seal tiles
kidding.
again. So
So I'm going to look at. No, one time that crossed the line, I had a patient that coded and passed, okay? And we had the doors closed, but our unit had it where like 3/4, there were glass doors, right? And 3/4, of the door is, if you're looking at it, I'm trying to think how to describe it. Like the bottom of the door is a window, and the rest is like that, like a blind thing. So if you really wanted to look and lean down in and look into the room, you could, which is kind of a safety measure, which is why you can't just totally block out all the windows. So people can always see in, but they have to kind of work for it. I've got this patient literally in a body bag. And this woman, who was a family member of another patient, is leaning into the room, trying to see what's going on.
Ridiculous.
OMG.
be subtle. Be subtle, guys.
Come on, guys. Be subtle if you want to look at that. Gosh. Just don't look at that. But I digress. What were we talking about?
Well, let me just say, my favorite thing is when patients are in separate rooms down the hall, and let's just say somebody's confused and they're yelling out, help me. And then that other patient's like, I'm coming to help you. I'll be right there.
Oh my God. No.
Hold on.
That reminds me of my favorite was when I had patients that had
They start talking
semi-private
to one
rooms.
another.
Semi-private rooms. So 2 patients, 1 room. They were both hard of hearing. So, and neither had their hearing aids. So I go in to talk to Mr. Smith. Mr. Smith, do you need to have a bowel movement? What? And so I'm screaming at Mr. Smith about his bowel movement. And every time I say something to him, I hear from through the curtain his roommate say, what? And then I'm like,
funny.
oh my God, I can't. I felt like I was in an SNL skit. Like I couldn't talk to one of them without the other one thinking that the other guy was being spoken to. And they both were like one of like 15 brothers and sisters. And each of them, without hearing the other person, started naming their siblings slowly.
Out loud.
So I was like, so his brother was in the room, and I was like, oh, you got any other brothers? Yeah, I got like 16 more. Albert. And then he started going on. And then the next guy, I went next door, and he starts doing the same freaking thing. I was in there for like 4 hours, I felt like, trying to make sense of it all. What is this podcast on? Documentation.
Yeah. We had to laugh, though, because... Okay, we just needed to laugh.
Nurse life. So documentation. I want to encourage you guys chart in real time. So my little trick is to, when you might not be able to, chart the whole assessment. Ideally, what you do is you go into the room, assess the patient, then give them their meds, and while they're taking their meds, chart your assessment. But if you can't chart your whole assessment, I want to encourage you to just chart the abnormals, because there are a lot of things that you chart on everybody. The various body systems are normal. I've done my rounding. I've done this. I've done that. I've done that. But just chart the abnormals if you don't have time. That way it timestamps it, number one, but then it also lets you know of the things you don't want to forget. So that's my little trick that I encourage you to use to kind of be more efficient on time. So, and then you don't have to struggle to remember it or try to struggle and write it down and that kind of thing.
What is this multitasking you speak of? This is nonsense.
Nurses shouldn't multitask. No, just kidding. That's all we do, right?
Yeah,
It's the iceberg
What you
visual,
see versus what nurses are
what's
actually
really
doing.
going on.
I'll
right.
put that in the show notes.
Right. Like, it really bothers me when I hear people saying, all they do is sit at the computer. And I'm like,
Well, we're like frantically charting and still getting out of work an hour late. I don't know.
right. They're like, all they do is hang out at the computer. What are they doing?
It's like, I am not checking Facebook, I promise.
Yeah.
Anyways, another thing, always chart objectively. So if you walk into a patient's room and you see that they're on the ground, never chart the patient fell, because you didn't see that patient fall. You don't know what happened. Like, you can't legally say that the patient fell or not. So, charting the patient, walked into room, patient found on floor is what you can say. And then if the patient said, I fell, then you chart, patient stated, I fell. Like, you have to chart things objectively, and don't put your opinion in anything, if that makes sense. And making sure that you're painting appropriate clinical picture. So I've done some peer review, chart review stuff where something actually did go wrong. A patient didn't do well because of something someone did or did not do. And so we're going back looking at the chart. Okay, what was going on with this patient? And the nurse barely charted anything. So I have no idea what was going on.
Well, and if you have no idea, then was that nurse even present?
Exactly. It opens up all these legal things, And so it's really important that you are kind of, again, documenting as if you'd be reading this in a courtroom in 5 years.
Right.
So that's real. I can't tell you how important that is. And
I actually, we have we used to do a lot of narrative stuff on paper charting, which I liked. This doesn't allow you to do that as much.
You can do
so
nurses
I annotate notes all the time when you're going through those assessment grids, but I do nursing notes, and I do them kind of often, especially if I have an issue and I've contacted the physician or something like that.
Oh yeah.
Or, the patient, has had. Well, I had a patient, who had respiratory distress the other night, ended up getting intubated, and I wrote a note because I needed to kind of say, this is what I saw, this is what was going on, this is what we did, this was the response to those interventions. To paint this picture. And what I think one of the hardest things is you don't have time to chart in that moment, especially if you're going through an emergency.
Right.
So I write things down. I literally took a piece of tape and I was like, we gave this med at this time, da-da-da-da. And then I took that piece of tape later and went and charted it, which...
And I think people think too, if my patient did bad, that meant I did bad. But sometimes patients crump, or sometimes patients just don't do well. And you just need to document objectively and what happened. And that doesn't mean you're a bad nurse. It's just something happened. So other things I want to make sure you're charting or keeping in mind: only use acceptable abbreviations in official charting. So, if peripheral IV, if PIV is not an acceptable thing per your hospital, you shouldn't be using that in documentation. Next thing. It is really important for you to follow up on all abnormal things. So if a patient has abnormal vital signs, and you treated them, charting what you're charting, okay, maybe they had a blood pressure of 190 over 110, and that you gave medication, and checking the follow-up blood pressure after you maybe gave 5 milligrams of IV low pressure or something like that.
Yeah, and there's a lot of areas you can duplicate charting, like you can, so... Sometimes in the MAR, if you're scanning a med for a certain blood pressure, I document the blood pressure in that in the comments under the MAR. You want to kind of save yourself from doing a lot of duplicate charting, because I think that leaves room for error.
It does, and it just creates more work.
It creates more work. But yeah, it's what were you saying? I'm so sorry.
No, just talking about following up on abnormals.
I need more coffee.
I know, right? So things that came to mind specifically are pain. Actually, you legally need to follow up if you give someone a pain medication. You must follow up appropriately. So pain.
That's Joint Commission.
It is. You have to do that. So if you give somebody a pain medication, you got to follow up within a certain amount of time and with a reassessment. Vitals, needs for restraints, and PRN medications. Really important that you're following up on all those things.
Another thing I think too, in the ICU setting now, is especially if you're using sedation medications, documenting a sedation score, whatever hospital or whatever sedation scoring tool your facility uses, that is a big deal right now. I know that Joint Commission is looking at, so if you're in the ICU and you're using propofol as a sedation drug for whatever reason, that when you make changes to the propofol, that you're documenting a sedation score with that. Because they need to know, well, why did you go up on this? You know?
Yes, absolutely. There's the Richmond agitation and sedation scale. There's the Riker's.
The RAS. We call it the RAS.
There's one that's RAS, Riker assessment.
There's RASS, which is what I'm familiar with the most.
Mm-hmm. And then which is, one scale. There's a couple scales, but they're essentially kind of very, very similar. And it's like, basically, you don't want to have someone too sedated. And you need to chart the level of sedation because someone can be lightly sedated or someone can be extremely heavily sedated. And if someone is heavily sedated, you can't assess them appropriately or tell if things are going wrong.
Right.
And so a lot of physicians will put in an order that they want a RAS of a -2, or they want a or RASS of -2 and RAS of -1, And that's just saying, hey, I want the patient to be asleep, but I want them to be able, if you touch their hand or you try to wake them up, that they can wake up quickly and easily. They're not so sedated that they're, completely unresponsive to pain or something like that.
And then the POS scale is the pain. That's the sedation? I don't know if it's POSS.
I'm not familiar with that one.
It's Passero something sedation, and we use that. We actually have to use that too, but we use that after we give some kind of narcotic pain med.
Oh, okay.
To make sure we're not over sedating them from narcotics,
which is a big deal because you can also kill somebody doing that.
Right. So it's a lot of charting, but that is a big deal right now. Is things that they're looking at in the charts is making sure we're documenting that.
With the stressed importance of charting and documenting as you go, are there things right now, technologically wise, that would help you all to document smoother, more in the moment, whether that's recording devices or technological apps with your phones, or is it all still
a lot
just
of
paper?
And there's very minimal paper, but especially with these EHRs, but there's various capabilities like, in the ICU, our vital sign machines automatically feed in vitals. So we just have to verify that they're okay, which is wonderful because that saves a lot of work. But there's also another capability where you can copy and paste, which is helpful, but it's also people get in the habit, and actually that brings me to my next point. People get into the habit of copying and pasting and not double checking. And then they're charting things that are not right. So like our title of this episode is, if it wasn't documented, it wasn't done. But also my second part of that is, just because it was documented doesn't mean it was done.
Subtitled.
Subtitle, yes.
What did you say?
So just because it was documented doesn't mean it was done, because people will copy and paste things that they didn't necessarily do or see just to fill in the holes of the charting.
I've worked in places, though, that you don't copy paste. So if your assessment is unchanged, there is a pull tab an option below that says unchanged.
Oh, okay. Yeah. I think it depends on the unit. Like, I know some facilities that say, yes, you can copy and paste your own work. But at the same time, my thought is, how are you able to monitor that, I guess? But follow your policies and procedures. And that also is another big point, is to know your hospital's documentation policies, because I'm someone that is like, if I don't have to document something, I'm not going to do it. Right. Like, why should I spend time to because I know nurses that want to fill in all the little boxes. Like, I'm not spending another hour of my day just to make it so it looks nice.
Right.
I want to put in what's necessary. It's almost like the nurse that's more worried about filling out her report sheet and getting all the boxes checked off than actually learning about the patient, It's like, okay, no, I need you to stop checking boxes and listen to me.
Right.
And I feel like it's the same thing with the electronic medical record. Like, you don't have to have every box filled in. That is actually incredibly inefficient.
And I know that there are things that will pop up. Our electronic medical record also has a work list, which gives us kind of what we need to do every hour. And I know the work list can sometimes give you pointers as to,
love the work list.
It's time to chart this. It's time to chart this. You just gave that pain medicine 30 minutes ago. You need to chart
yes.
a reassessment by now, or at so-and-so time.
I love those work lists because I forget about that
Yeah,
stuff.
I live and breathe by that thing.
Yeah, so encourage you guys to use it if it's not required already. One thing I did as a new grad was I would create a checklist on my report sheet at the bottom. Real quick, I drew a little heart to make sure I remembered my telestrip. I wrote assess, and then CP for care plans, and then EDU for education, IVs, and meds. And once I got everything charted or that charted, like, my telestrip, that's pretty quick. And then care plans, education, I'd have to wait till the afternoon, but, just check. I got everything situated. And then once I had that kind of it took me a little while to remember that because I would find myself forgetting little pieces of charting, especially with discharges and admissions. So if you can, like, when you're getting report, either already have that as part of your report sheet or kind of jot it at the bottom and check it off as you get it done, that can be a really helpful reminder to you. Yeah.
And let's go to care plan and education because that's another big deal that Joint Commission is looking at, making sure we are evaluating or creating patient care plans, looking at those care plans on a shift-to-shift or day-by-day basis, making sure we're documenting whether or not how the patient is doing in that plan of care. And those care plans, guys, are your good old nursing diagnoses.
Oh, yeah. Nanda,
They're
Nick,
never
and Knock,
going
baby.
away. Never going away.
And I think people think those are like I hated care plans in school, but now that I'm a nurse and been a nurse for a while, they totally matter. Like it's like, and you even do them in the emergency department. You're not like documenting them. Like you're doing them at lightning speed in the emergency department and sometimes in the ICUs. But it's like, if you're turning your patient every 2 hours, you're doing a care plan.
Yeah.
If
you're helping prevent pressure ulcer.
Right. If you are putting those little sakis on your patient before they get out of bed, you're preventing falls. Hey, that's a care plan.
Yeah.
Like there's so many things that you just instinctively do as a nurse that are part of a care plan.
Yeah.
And it's important for you to progress your patients within these care plans and document on them appropriately, and don't just write progress when they're not really progressing. Like,
right.
And one of the things I think people think is if they don't put that they're progressing, then they're not doing what they need to as a nurse.
And here's a good scenario. So Joint Commission's coming in, and I'm going to talk about Joint Commission a lot because this is such a big deal. But Joint Commission comes in. Let's say you, let me think. I'm going to use another stroke patient. Joint Commission comes in, and your patient has had a stroke. And they are, let's say they failed their swallowing evaluation and we're giving them nutrition through a feeding tube. Let's say they've been having a lot of problems tolerating those feeding tubes for whatever reason. So Joint Commission's coming in. They're going to pull you into a little room. They're going to pull you as the nurse into a little room. And be like,
I've been pulled into that room.
Yeah. And they're going to be like, so tell me what's going on. I see on the chart that your patient hasn't gotten any nutrition in 24 hours. The tube feeds aren't going. What's going on there? And they're going to say, tell me in that care plan where you've documented progressing. They're meeting 100% of their nutrition needs, but this patient hasn't been getting nutrition for 24 hours. What's going on with that? They're going to ask you those questions. So it's a big deal.
It's a big deal. And
they're not there to punish you, but
if you are documenting that they're progressing and they're
not,
clearly not, that is your fault.
Right.
Sorry, y'all. You can't just put progressing.
You can say not progressing, patient having multiple, whatever.
Yeah.
Blah, blah, blah. I don't know. I don't want to get into too many details. But those care plans, and you can change them. You can add more to them.
I can't tell you. I'll come into on my patient and it's like, oh, wait, these are not applicable. Resolve. Actually, I'm going to put in the care plan that is applicable.
Right.
Like, don't just open care plans to have them. Like, critically think about what is important for this patient and put in what's appropriate and resolve what's not.
Right.
Like, I think some people are scared to do that because they don't want to get in trouble, but you get what? Like, I think if you just use common sense with the charting, it makes sense. And that brings me to my last point about, things people with charting, and I get report on a patient and I'll see that it has listed that the patient has an ART line and an IV that aren't in the patient.
Right.
And then I ask the last nurse, hey, this is in the chart, but they're not physically in the patient. And the nurse will say, well, I didn't put them in, so I'm not touching that charting because I didn't do it. But it's like, so you had this patient for 12 hours and it said that the patient had an art line and it looks like you just didn't even look at it.
Yeah.
So, and
That's a good point.
I've been to a bunch of charting things. I've talked to lawyers just in my offline nurse life. And it's like, you leaving it alone looks worse. What you have to do is remove it from documentation, because if you leave it in the doc flow, you leave it in there, it looks like this patient had a line that wasn't looked at for however long. And you know what? Maybe the only reason that was entered in the first place was because someone put it on the wrong patient. But now we run all these reports to see which patients have central lines, and then we have this central line that hasn't been touched for 2 weeks.
For 576 days, because they had it on the previous admission.
And somebody put it in on accident and never removed
took it out. Yeah.
And then it screws everything up.
Ugh, such a big deal.
Such a big deal. So if you get report, and again, make sure you're looking at your policies and procedures. But generally speaking, it's like, if you don't see it on assessment, well, this is what I do. I remove it from the doc flow. I chart a little note. This was not present during assessment. And then if somebody goes back to look, it's like, and I'm charting, I have no idea when it was here, if it was here, or when it was discontinued. But when I laid my eyes on this patient at 6:45 in the morning, they did not have an art line or a central line or an IV. But they're all in the doc flow. So I really encourage you to look at your policies and procedures and making sure that you're not just like leaving something to hang out, making sure that it gets addressed appropriately so the documentation reacts or reflects appropriately what's going on with the patient.
Good point.
I think that's. You got anything else to add about documentation?
No, it's document education too. Education is such a big deal. That's how we get reimbursed in some situations.
And document what you actually
with core measures and all that stuff. If you haven't heard about core measures, oh my gosh, you will hear about them.
That could be its own show.
It needs to be.
Yeah, season 2.
But and maybe one day we can actually have season 2. We can have someone come in and talk to us who does more legal. Or have been in a lot more malpractice cases and talk to us about what's good documentation versus what's not.
Yeah, I think that would be beneficial.
Especially with talking about scenarios and narrative stuff. Narrative stuff. Because what are some things that litigation will look at?
Yeah, so that's important to consider, when you're looking at this stuff. So,
but honestly, sometimes I would say too much is better than not enough.
Yeah, legally, too much is better than not enough, but also make sure what you're documenting, you're actually doing.
It's real.
And if you're documenting that you educated on blank, that you actually educated them on it. And if you're documenting about range of motion, that you're actually doing it. You're not just copying and pasting. So that's a little info on documentation for you newbie nurses. Remember, document as if you're reading it. You're going to be reading it in a courtroom in 5 years, y'all. Just keep that in mind. So check out freshrn.com/podcast. I will have some show notes there and I have actually found a really great resource or just a really good blog post written by a nurse. Like, I don't know, it's a few years old, but I thought it was really concise and really good. So I'm going to put a link to that in these show notes. So check that out, freshrn.com/podcast. And go ahead and check out freshrn.com. I've got some great gear and great resources and books and recommended loveliness. So go check that out. And thank you
Every
so
time
much
I hear
for listening.
Fresh RN, I think of that 80s song, She's Fresh. What's that song? I'm not going to sing it. But
Oh, you're not going to sing? It is on iTunes.
Oh, you have to sing, otherwise I'm going to start chanting.
I'm not going to sing it, but it's an 80s song. It's by Kool and the Gang, and it's like, she's fresh. She's so fresh. She's so fresh. Anyway, that's enough.
But then you can look at the Fresh
I got
RN.
it. I did it.
You got it? You're good. But then the Fresh RN is so fresh right now. You know how people say instead of like right out right now, they put RN, so Fresh RN. Okay, sorry. All right, I digress. So check it out. Thank you guys so much for listening and stay fresh.
Thanks, guys.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you scream. I don't believe in playing it safe. I got the urge to miss.